year-to-year basis, the number of positions that were vacant, the number that you actually filled each year with civil servants, and I guess the remainder of that would be the number that you've been unable to fill. And then I'd like to know as well, how many applications did DMH receive each year for this position?
Okay.
And then I guess the other thing is, do you maintain a list of those who are eligible to fill the positions? Is there some sort of does the process involve, in addition to an application, some sort of a listing?
Not necessarily. What we have been able to do is if someone applies to us, then we move them forward for credentialing and privileging. And we have had some people, after we've privileged them, that chose not to come to work. So we don't have like a registry or a list that we can draw from. Under the contracts, we do have some contractors that then can go out and solicit additional folks to come on to the contract. The other thing that we have done is, with the approval of Department of Personnel Administration and working with the unions, is we do have some folks in what we consider a second position. So we have some psychiatrists that are working the equivalent of two positions. There's just a change in, they can't draw benefits for both positions, and they can do only a limited number of hours in that second position. So that's another option that we have pursued while we've had these vacancies.
There's not some group of individuals who are psychiatrists who are, I think the term of art is list eligible, or who are somehow on a list of those who are eligible?
Those would be folks that, if I understand what you're asking, the list eligibles would be folks that go through what's called a QAP, a qualifications appraisal panel, that puts them on the list for hiring. We're hiring those lists as soon as we have vacancies, which we have. So there are very few people sitting on a list unless it's somebody new that out of state we're recruiting. We get them on the QAP, and as soon as possible we hire them and bring them in.
So again, I guess for each of those 4 years, so 6, 7, 8, 9, now 10, if you could provide the committee with the number of people that were on this list that were qualified to be brought into a position, that would be helpful as well. And then you alluded to your view that pay is now consistent with benefits. Can you share with us, I mean, what's the amount of compensation that the non-civil service contractors are receiving on an annualized basis versus the average pay for a civil servant psychiatrist on an annual basis?
The manner in which contracts are done, the psychiatry contracts are bid. So the way we use those, you actually will go to the person who had a lower bid, if you will, and then if you need additional hours to fill your vacant rates, then you would go on to the personnel who may have had a higher bid. The range is somewhere between 170 all the way up to, I believe it was 200 even. And that would be a cap, because we did cap the amount that we would pay any contractor. When we first began the emergency contracts, the cap was not in place for any department utilizing this. We worked on bringing those amounts down so that we had, first of all, a better recruitment pool, because we were hoping to recruit people into civil service, and there was not that gap in disparity. If you took account for the civil service positions and their benefit package and the fact that their insurance is covered, malpractice, what have you, through the course of time, it's consistent somewhere in the neighborhood of $170 to $185 per hour. So when you add the benefits into
So you don't
pay.
believe there's any cost differential for the use of the contractors versus the civil servant psychiatrists?
I do believe there is probably, depending upon the contractor, $10 or $12 potentially an hour if you were to average that. But as the State Personnel Board had ruled when we were going through this process, they are consistent enough to still vie for recruitment, if you will. A contractor does not work overtime. They do not work additional hours. They're only paid for the time they work. They have to pay their own benefits. They have to pay their own malpractice insurance. They have to provide their own pay for CEUs as continuing medical educational units that they need. So there are a number of things that the contractor would pay for, where if you're in civil service, it is all a part of your benefit package. So when they looked at that, they felt that things were consistent.
Okay, so can you provide the committee then with a written analysis that for each of those years compares the cost to the state of the contractors versus the cost of the civil servant psychiatrists? And I'd like those to be based on empirical information. That is to say, in that given year, what was the cost of the contractors and what was the cost of the civil servant psychiatrists, both in the aggregate and then also broken down on an individualized basis. And so it would be helpful to have that analysis for each of those years. But even given what you've just said, which is a $10 to $12 difference on average, I mean, won't that have some bearing on your ability to recruit civil servant psychiatrists, even at that differential?
We've been hiring into civil service class. I think part of what the difficulty is nationally, we don't have enough of these clinicians out there. With all the recruitment efforts we have, nationally they're not available. We provide, in addition to the second positions that Ms. Radowski just mentioned, we also provide psychiatric fellowships at several of our facilities for forensic psychiatry, specifically for recruitment efforts. We're doing what we can, but we don't have large numbers of pools, if you will, of these clinicians to recruit from.
Now, you said a moment ago that the contractors cannot work overtime, because the information I have is that they could work up to 60 hours a week.
Only at the hourly rate. They receive no overtime compensation for that.
Okay, but so they can work overtime, it's just they don't get time and a half for it.
That's correct, and our civil service doctors cannot work overtime either. So, that's why some of them are in second positions or an alternate work schedule, because their contracts do not allow them to receive overtime at time and a half either.
Okay, but are the contracts, I guess the question I'm getting at is, are contractors in some case being utilized more than a 40-hour work week, such that their total compensation for the year may be higher than the $200,000 cap?
We can get you data as it relates to that. Sure. Hospitals attempt to leave their contractors at a 40-hour week. It's pretty rare that they go beyond that. The contractors are not allowed to do, for example, what we call physician on duty call, some of these other things that the civil service psychiatrists and doctors have the ability to do that increases their salary, if you will, depending upon their on-call status. We do not use our contractors in that manner.
Okay, I would like to see on an annualized basis information about the extent to which the contractors are exceeding a 40-hour work week and what their compensation is as a result of that. Then I guess the consent decree expires in November of 2011 is my understanding. That's the hope?
Yes, sir, that's the hope. The way the consent judgment was written is we need to bring the 4 hospitals into compliance by November of 2009 and then maintain for 18 months. So they gave us 6 months of play. So we should be completed by November 2011.
So what's the department's plan at that point going forward with regard to the continued utilization of contractors? Or conversely, what's your plan to try to fill the civil servant vacancies that I believe may exist?
Well, we'll continue to recruit whether we have the consent judgment or not. We have to have a set number of staff in order to maintain a number of patients based on licensing staffing ratios, whether that's rehabilitation therapists, psychologists, psychiatrists. So we have staffing standards. If we do not have civil servants and then cannot fill behind with contractors if there's vacancies, we have to reduce the population. So that's not driven by the consent judgment. That is driven by state staffing standards.
And then going back to the cost differential, what's the maximum a civil service psychiatrist can make? Because you mentioned a $200,000 cap on the contractors. Is there a...
I can actually put that in the data we provide you. I don't have that off the top of my head.
Okay, that would be helpful too. And then I remain concerned that there is a differential between the cost to the state of utilizing the contractors versus the cost of utilizing the civil servant psychiatrists. And I guess I'm wondering if the department has any thoughts on how to manage that cost differential, or if there's anything that can be done to try to address that cost differential, if I'm correct that it exists.
Well, I think we continue to work with the other departments that are using psychiatrists, because that was one of the reasons we capped the contracts, was we did not want to start a bidding war amongst all the departments that used them. We will continue to actively recruit, and we're looking actually at some psychiatric nursing as well that might be able to supplement and provide some of the services if we're continuing to have a national shortage of psychiatrists. We're just not seeing the graduates coming out of the medical schools that are interested in forensic psychiatry and or working within the hospitals.
And then one last question on the recruitment issue. How many open examinations did you conduct in each of the last 4 years for psychiatrists?
We can look that up. That is continuous testing. So anytime somebody turns in an application, one of the hospitals and or our headquarters will do a quality appraisal panel and put them on the list to make them list eligible so that we can hire. That testing happens almost weekly.
Did you want to add
We don't wait for an accumulation of applicants. If we find we have two that submitted their applications, and particularly in these highly sought clinical fields, we immediately conduct those qualifications appraisals and get them moving through the process.
Okay. If you could provide us with information about the frequency of the testing, then that would be helpful as well. So the underlying concern I have is in many other cases, I've seen evidence to indicate that the utilization of contractors versus full-time civil servants is more expensive. And that's my concern here. And so I appreciate your willingness to provide us answers to these questions, because as the subcommittee with oversight responsibilities for this portion of the budget, I think we need to have a better understanding of what the cost differentials are and a better understanding of whether or not it is the case that this is costing us more. Based on the evidence I have, I am concerned that it is, but I want to give you a chance to provide the information that we've requested. Let me see if any other members of the committee have any questions at this time. We've been joined by Mr. Bell, Mr. Hill, and Mr. Chesbrough. Welcome. Why don't we go ahead and establish a quorum, since we seem to have one? Seize the moment.
Jones.
Here.
Bell. Chesbrough. Here. Hill. Here. Emerson. Here. Nastandi.
Okay, let me see if there are any members of the public who would wish to testify on this item. Okay, very good. Thank you very much. Oh, anything from either LAO or Department of Finance? Nothing for Finance, LAO?
Mr. Chair and members, Greg Jolivet with the Legislative Analyst Office. We had no concerns with the issues, though we would note that the budget does include 7.5 positions on non-level of care staff at a little under $1 million for Coalinga State Hospital related to the implementation of CRIPA.
Okay. Thank you again. And you understand the concern that I have. I appreciate the additional information, and I'd be also most appreciative of any further elaboration you could provide with regard to what your plan going forward is going to be after November of 2011. Thank you very much. We're going to move now to the Department of Public Health, which is item 4265, and I'd like to invite the representatives of the department forward. I also just want to ask if the staff could agendize a matter for this Wednesday, which is a matter that Mr. Chesbrough has brought to the attention of the committee that deals with licensed and certified institutions that are dealing with mental health issues. and I'm wondering if we could agendize that to be discussed on Wednesday. There's a request for some trailer bill language, and so I'm going to ask if the committee can put that on the agenda for Wednesday, Mr. Chesbrough's request. Absolutely. So I want to welcome you to the committee, and perhaps you could introduce yourselves, and then we'll just plunge in. I think you're first going to provide us with an overview, and then we've got some specific issues we want to go through.
Mr. Chairman, members, Dr. Kevin Riley with the California Department of Public Health. I'm the Chief Deputy Director for Policy and Programs. Do you want to introduce? Or?
Hello again.
John Doyle, Department of Finance.
Ellen Marati, Department of Finance.
Okay, would you like to provide us with a quick overview of the department?
Very good, Mr. Chair.
Thank you.
I believe staff did an excellent job in the write-up in terms of a high-altitude or high-level description of our programs. From a wide perspective, the department runs well over 100 different programmatic elements, program activities. They range from drinking water, environmental programs, to infectious disease, Office of AIDS programs, infectious disease immunizations. We have a very wide gamut of activities. We work very closely with local health jurisdictions and community partners in implementing those programs. Our basic objective is to improve community health, in particular quality and now quantity, and as well as quality of life. That's been an evolution in the last decade, that we are looking at preventative measures. The phrase that's often used is moving upstream to the causes of health outcomes. So that's best illustrated perhaps with the governor's obesity initiative that has taken it's on the move. It's a very exciting set of activities, piece of legislation before the legislature right now. We're very excited about moving forward with the obesity initiative under the governor's leadership.
Very good. Any questions from members of the committee on the overview? Comments from Finance or LAO? Okay, why don't we move now to the first issue, which is on page 6 of the briefing materials, which deals with maternal, child, adolescent health programs. Is there someone here that'd like to present on that?
Good morning. I'm Vicki Orlick, the Assistant Deputy Director for the Center for Family Health. And the Center for Family Health does oversee the maternal, child, and adolescent health program, and also the former domestic violence program. Just to recap, the 2009-10 cuts for maternal and child health eliminated $20.3 million from the maternal and child adolescent health program. That did impact the Black Infant Health Program. There was elimination of $3.9 million. And then for the Adolescent Family Program, there was an elimination of $10.7 million. And then for the county MCAH grants, that was an additional $2.1 million. What's important to remember, though, is that in the elimination, also matching funds are eliminated. We're unable to draw down the federal money. So we don't have any data yet as to what the impact will be. We've made estimates, but our data won't come in until the end of the year, and it'll take a few months to compile that information.
Okay, thank you. Anything from the Department of Finance or LAO?
Nothing to add.
Okay.
Thank you,
LAO?
Mr. Chair, members. Lisa Morawski with the Legislative Analyst's Office. We are working with the department to identify the impacts of these cuts.
Okay, the recommended action is to restore the $12 million that the governor unilaterally cut from this budget at the end of that's actually the beginning of last year, I guess. Members of the public would like to testify on this item?
Beth Capel on behalf of Health Access California. Just to take note that later on your agenda, you'll be discussing the 1115 waiver. An important component of that is children with special health care needs. There is no better way to avoid children having special health care needs than to invest in maternal health. And these cuts in particular are sure to increase, the veto that the governor did, are sure to increase the number of children with special health care needs and who will have lifelong health and social needs. So we commend the chair's motion.
Thank you. Any other members of the public wish to testify on this item? Any questions from members of the committee? Okay, seeing none, the chair will look for a motion to restore. Oh, there are people outside who wish to testify. Although maybe not on this item. Okay, so this is the item dealing with maternal child adolescent health. The recommended action is to restore the $12 million cut that the governor unilaterally imposed last year. Welcome.
Thank you very much. And unfortunately, I missed the discussion, but just wanted Anne Marie from Planned Parenthood Affiliates of California. A lot of our affiliates are involved with several of these programs, including the Adolescent Family Life Program and the Black Infant Health Program, and we would strongly support refunding these programs.
Thank you.
Thank you.
We're going to move to a bigger room, I promise you, after the session. Okay, very good.
I'll move the recommendation.
There's a motion from Mr. Chesrow, a second from Mr. Hill. The motion is to restore the $12 million that were cut by the governor in the last year, restore that in this year's budget. Let's call the roll.
Jones.
Aye.
Bell. Chesbro. Hill. Emerson. Nistandy.
Okay, motion carries. Issue number 3, domestic violence shelters, the governor's 2009 veto.
This effectively eliminated the domestic violence program within the Department of Public Health. It was, I believe, $20.4 million total dollars in general fund. But subsequent to that, there was a bill enacted to take the money, and I forgot the name of the fund. It might be the Victims Compensation Fund. It was a loan, and to provide that funding at CalEMA. So to the extent that our domestic shelter violence, our domestic violence shelters were able to access those funds, we don't have that information. We do know that of our 94 domestic violence shelters, about 79 were also receiving CalEMA funds. Perhaps maybe 3 to 5 shelters have closed as a result of this, but we really don't have the specifics on that.
Okay. Anything from Finance or LAO? Can you ask if there's anyone who wishes to testify on the domestic violence shelters issue? Members of the public?
Thank you. Michael Martinez, representing the California Partnership on Domestic Violence, which is the statewide domestic violence trade association. And I've been working with Assembly Budget Sub 4 on this issue as indicated.
Very effectively, I might add, because Sub 4, I guess, restored the funding, which obviates the need for us to take an action here. So my recommendation is that we not act here unless there's some strong other sentiment. I'm sorry to interrupt. Go ahead.
No worries, Dave. I just did want to say with regard to the representative, about 6, from my understanding, there was a lag time in between when the budget was enacted and the money from SBX 313 was actually doled out to the various domestic violence shelters throughout the state. That about 6 shelters did close. And so this money actually is very, very necessary to continue to list lifeline for many shelters throughout the state. So again, thank you to this committee for at least hearing this item, and then of course Assembly Budget Sub 4. Thank you.
Jespro.
I don't know if it would create jurisdictional confusion for us to vote to affirm Sub 4's previous action. They do have obviously the jurisdiction over it now, but I want to say, just speaking from my district, having visited the domestic violence shelters, those shelters immediately upon the veto laid people off and drastically curtailed services. Most of them have not rehired because they didn't have confidence that, and hopefully we can reestablish that confidence if the governor will, if we can get this in the budget and the governor doesn't veto it again. But they have basically been operating with volunteers with drastically reduced services, and I just think it's plain wrong. And I'd love for this committee to make that statement in affirmation of Sub 4's actions. So, if that's acceptable to the chair.
I don't know why not.
It doesn't have any formal.
Go ahead.
Well, we could probably do that all day long, though, if we're just going to reaffirm other committees' votes. I don't know what the point of that would be.
Well, let me ask a question of the consultant. This falls within the Department of Public Health's budget? Is that right?
It's been moved.
Not anymore. Oh, it's been moved. Oh, I see. So it's been moved out of the budget. Okay. Well, I think it's. I appreciate your suggestion. I also appreciate the concern raised by Mr. Nastandi. I think I'm sure it's the will of the majority of this committee to support that action. If we could,
just trying to send as loud
okay.
and clear a message to the governor as possible that it was one of his worst actions last year. I think totally eliminating the funding was just inexcusable.
Absolutely, Mr. Hill.
Well, I was just going to say I think we can all agree to that, and at least the majority of the committee, and I think this statement is a loud and clear statement to the governor just by our comments and the actions taken by Kalima on that too, in some form.
Very good. Well, I appreciate Mr. Chesbro, Mr. Hill, Mr. Bell.
Well, just responding to maybe Mr. Nastandi's comment. This was something that the legislature put in the budget, and then later on the governor came and took it out, and then we put it back in by coming up with a special way of funding it. So it wasn't something that we as the legislature took out of the budget. It was something the governor blue penciled out. So last year when we approved the budget, this particular item was in the budget, and then it was taken out, and then we passed the subsequent legislation by Senator Alquist to fund it on an interim basis with the special funds. So as a result of this, I think this is entirely in keeping with last year's action by the entire legislature that we had this in the budget, and I think we ought to say today that yes, we want to keep it in the budget. And so I would support the common sense direction that you suggest.
Okay, I appreciate that. So I think there's clearly 4 of us on record saying it should be restored. I think the consultant has apprised us, though, that jurisdictionally it falls within Sub 4's budget. So I think we're going to just acknowledge their decision, not take a formal motion here because of the jurisdictional issue. But I think it's those of us who have a keen concern about this, and I appreciate your historical explanation, Mr. Bell, as well, want to see this money restored. With that, then, let's move to issue number 4, Every Woman Counts, the Every Woman Counts program, and let's hear from the department on that. Welcome.
Hi, I'm Linda Rudolph. I'm the Deputy Director in the Department of Public Health for the Center for Chronic Disease Prevention and Health Promotion. Every Woman Counts is a program that provides breast and cervical cancer treatment screening services to women who don't have another source of insurance for those services and who are under 200% of federal poverty level. And the program has been facing a funding shortage that's due both to increasing caseload and a decline in tobacco tax revenues, which are the primary source of funding for this program, although we also get some funding from the Centers for Disease Control. That's federal funding. In January of this year, we put into effect 2 significant policy changes to try and address this shortfall. One was that we increased the minimum age eligibility for breast cancer screening services from age 40 to age 50. And 2, we instituted a temporary 6-month freeze on enrollment for all women from January 1st through June 30th so that we could live within our budget. We've had discussions with stakeholders looking for ways to basically bring program costs into alignment with current program revenues, and we will be submitting a May revise letter that outlines some additional cost savings that we propose after we complete our projections on the budget impacts of those proposals.
Okay, thank you. Finance? Anyone from Finance? LAO? Okay. Can you ask if there's anyone who wishes to testify out in the hallway or anyone in the room would like to testify? The action I'm going to recommend to the committee is that we reject the governor's trigger proposal to shift $22 million in Prop 99 funding from this program to Medi-Cal, that would require DPH to annually provide the legislature with an estimate on the Every Woman's Count program by no later than January 10th and May 14th of each year so we can perform our oversight function better, and that we also augment this budget in order to meet demand for services without the eligibility restrictions that were put into place this year. So those are going to be the actions I recommend the committee take, and I would ask that the members of the public govern their testimony accordingly. Mr. Emerson, you have a question, sir, before we start.
Yes, I would like to request that we divide those into 3 separate votes.
Very good.
All right.
Okay.
Thank you.
Perfectly reasonable. Yes. So we'll divide those into 3 separate votes. Let's hear from the public.
Thank you. Alicia Sanchez with the American Cancer Society. We support all of the chair's recommendations. In particular, I'd like to stress the importance from the American Cancer Society's perspective of the 40 to 50 screening. These are where we recommend women, this is the age that we recommend women start screening annually. And I would note that approximately 17% of breast cancer deaths occur in women between that age. This is when these cancers tend to be very aggressive, and so we think it's critical to ensure that the program continue to serve this age group. And again, urge your support of the chair's recommendation. Thank you.
Thank you.
My name is Alice Schneid. I'm vice chair of the 7 affiliates of the Susan G. Komen for the Cure. I was 47 when I was diagnosed with breast cancer 11 years ago. If I had been a part of this program, who knows, with those 3 years in delay in my diagnosis, I may not be alive today. So I urge that the 40 to 49 be restored and to continue with the recommendations. Thank you very much.
Good morning, and thank you. Maureen O'Haron, representing the City of Hope, a comprehensive cancer treatment center in Southern California. We strongly support all the chair's recommendations. We would point out we're the largest provider of bone marrow transplant in the Medi-Cal program, and we just know that the costs are significant on the back end when you don't do this kind of diagnostic on the front end. Thank you.
Allison Ramey on behalf of the California Primary Care Association, representing over 800 community clinics and health centers. As our members serve roughly 1/3 of the women in the Every Woman Counts program, we fully support the recommendations by the chair. Thank you.
Anne-Marie Benitez with Planned Parenthood Affiliates of California. We also provide breast and cervical cancer screenings within our affiliates, and we strongly support the recommendations that the committee has just proposed at the table. Thank you very much.
Margaret Merritt with the American Congress of OBGYNs, and we too support the chair's recommendation.
Carolyn Jenna with the California Medical Association supported the chair's recommendations to fully fund this program. Thank you.
Okay, thank you. Any other members of the public wish to testify? Any questions from members of the committee? So we'll, Mr. Nastandi. Yes, sir.
Thank you, Mr. Chair. It's just, I know these are tough decisions, but I guess we're making these decisions in a vacuum in the sense of we're rejecting the governor's proposals, but then where are we backfilling that money somehow, or how are we counting this in the budget then?
So the total budget for this program, I'm told, is $63 million annually. What's happened is over time, the Prop 99 share of revenues for this program have declined. And so the third of the 3 actions I'm proposing is that we would backfill whatever this year's increment of decline is. So we're not expanding enrollment in the program or growth in the program. We're just trying to keep the program constant. But we're using a different fund source, which is the general fund. I don't think we will know until this subcommittee's actions are tied up with the other subcommittee's actions and until we see the May revise what the implications of that are for the overall budget and whether that means that we also need to look for revenues as well as cuts.
That's my question. So isn't it a little bit premature then to go through all this if we don't know the greater context of what's going to be happening in the budget, how you move the numbers around? We're making a statement based on partial information, I guess.
I think that it's sort of a chicken and egg. We have to start somewhere, and we are starting with the best information that we have, and we attempt to make deliberate decisions based on the best information, and so we're going to try to make as many decisions as we can right now, knowing that we're going to be getting in a few days the governor's May revise, which will allow us the opportunity to revise those decisions, and then there'll be a conference committee at which point there'll be additional revisions based on additional information and the tying up of all of the subcommittee's work. So we do operate a little bit in this subcommittee within some parameters, which is we only have our piece of the budget, and then ultimately it all gets tied together.
My other part of the question is, not just this item, but the previous ones also, are some members assuming that there's extra money to to backfill these, or my assumption is, well, I think the fact is we're, $18 billion short or whatever it is. So how are we calculating putting that money back in that the governor's proposing taking out if we're $18 billion short? I guess is my question.
Well, I think it's a combination of things. It could be cuts elsewhere in the budget, which may be happening in other subcommittees or may happen in the conference committee, and it may be additional revenues. I mean, we're going to have an item a little bit later on where, as a result of legislation that I carried, we're going to have $520 million in additional revenues coming into the budget, and so that's good news.
That's good news. Did you offset? I mean, did you, with that $520 million? I think you said. Did you identify where you wanted to place that money? Or?
Well, we're going to have a conversation about that a little bit later on in the agenda.
But going back to the general idea, though, the governor, I assume, since he's the one that proposes the budget, is that he's balanced all these equations, and he figures here's where we have to cut to balance that budget. So when we say we only act within our jurisdiction, correct, but we're not appropriators making up the budget. We're reacting to a budget. So if we make a decision different from the governor, I would assume we would have to then explain how we're arriving at that decision different than he did.
Well,
the necessity of a cut.
I have a very different view of our role as the legislature. We are the appropriators. We do adopt a budget. As a procedural matter, we start with the governor's budget, which is a proposal, and we use that as the organizing principle around which we build our own budget. But we adopt a legislative budget, and then it's for the governor to decide whether to sign that or not, and or whether to blue pencil portions of that. So you're right. At the end of the day, the actions we take in this subcommittee, coupled with the actions of the other subcommittee, will have to tie together, and we'll have to balance the budget. And the process for doing that is we take actions in subcommittees, as you know, and then it gets tied up together in an action ultimately that the conference committee takes, and that ultimately gets ratified by both houses.
I understand. I appreciate, Mr. Chairman, not to belabor too much. I'll just be amazed if it actually comes out balanced at the end of the day after all this, that if we all eat every word of it, then at the end of the day, if we have a balanced budget come June 30th. But thank you.
Stay tuned. Mr. Chesbrough.
And implicit in Mr. Nastandi's comments are that somehow the governor proposes it, we just have to accept it. And I just don't think that's, we very much have a role, item by item, issue by issue, to talk about what the legislature's priorities are. And, especially in light of the fact that we made a number of appropriate cuts to these programs, to sharing the responsibility for reductions that everybody's had to engage in. And then the governor completely eliminated funding with his vetoes. And so I think that was a complete rebuff of the legislature's attempt to say, okay, these programs have to share part of the burden. And then he comes in and says, no, I'm going to single out certain areas of the budget to completely eliminate funding for. And that was part of my outrage about the domestic violence program, but you could apply it equally here. That the legislature's involvement was completely overridden by his vetoes last year. So, we have a process. I think it's very important in these subcommittees that we talk about what the priorities of the legislature are, whether or not at the end of the day, when it goes in the negotiation process and we wind up voting on the floor, that's another story. But I think we have the ability to help influence that outcome by stating our preferences as members of these subcommittees and letting the governor know and our leadership know what our priorities are.
I have a suspicion. Wait, Mr. Stanley, I'm sorry, you haven't been recognized. I have a suspicion we could have a very lengthy debate about this issue. I think Mr. Emerson wants to add a final word.
Real quickly, sir, if I might.
Go ahead, Mr. Stanley.
Thank you, sir. We don't adopt a budget first and then react to it, which would be the normal case. Like in Congress, you adopt a budget, then your committees deal with, you have this amount because that all adds up to this greater number. We're going backwards. That's why we have to take the governor's budget, because that's the only budget there. And if we're undoing that without using the other side of the ledger, then I don't quite get the logic, I guess is the point. Unless we pass the budget first, saying, okay, now it's budget, now you go down to your subcommittees and build from there.
Okay, Mr.
Thank
Emerson,
you, Mr. Chair. I appreciate your time.
Mr. Stanley, thank you. Mr. Emerson, you wanted to add something?
Well, I think in last year's budget, we did not complete all that was requested. There are certain portions of the budget. We did some transfers from local government and a few things like that, and we didn't complete the full picture. So I'm sure that the governor, when he looked at this budget, he didn't have the revenue that he anticipated we would have from last year's budget. So I am going to abstain from a portion of these today, throughout the day, until we have the May revise, and I think we can more accurately work on a budget.
Fair enough. Thank you, gentlemen. So we've heard from the public. We've had questions from members. I'm going to take each of these in turn as the Vice Chair has requested. The first is I'm looking for a motion to reject the Governor's trigger proposal to shift all $22 million in Proposition 99 from this program, which is the Every Woman's Count program, to Medi-Cal for general fund savings. Is there a motion? There's a motion from Mr. Chesbro, a second from Mr. Hill. Let's call the roll on that motion.
Jones.
Aye.
Bell. Chesbro. Hill. Emerson. Nistandy.
The second motion is to require that the Department of Public Health provide annually to the legislature an estimate on the Every Woman's Count program by no later than January 10th and May 14th of each year. It's a motion from Mr. Emerson, a second from Mr. Chesbro. Let's call the roll on that motion.
Jones.
Aye.
Bell. Chesbro.
Aye.
Hill. Emerson. Nistandy.
Okay, that motion carries. The last motion is to augment the Governor's proposed budget for the Every Woman's Count program in an amount sufficient from the general fund in order to meet the current demand for services without the eligibility restrictions put into place this year. Looking for a motion. Mr. Chesbro moves. Mr. Hill seconds. Let's call the roll on that motion.
Jones.
Aye.
Bell. Chesbro.
Aye.
Hill. Emerson. And Nistandy.
That motion carries. Let's move now to issue number 5, which is the prostate cancer treatment program. Go ahead.
The prostate cancer treatment program provides treatment for people that are diagnosed with prostate cancer who are over the age of 18, under 200% of federal poverty level, and have no other source of insurance for prostate cancer treatment. This program, similar to the Every Woman Counts program, has had to put a freeze on enrollment, in this case primarily because of increases in the cost of treatment. So there's currently about a little over 14, probably 14 or 16 men on the waiting list. We expect that waiting list to grow through the end of the fiscal year.
Finance? Anything on this? No? LAO? Anyone from the public who wishes to testify? The sergeants ask if there's anybody outside who... You did? Okay. Issue 5, prostate cancer treatment program.
Alicia Sanchez with the American Cancer Society. Approximately 3,000 men in California will die from prostate cancer this year, and we think it's critical that those people that want treatment have the availability to seek it. So we urge you to fund the program.
Good morning. My name is Bill Doss, and I'm a facilitator for a local prostate cancer support group. I'm also a prostate cancer survivor. I'm here today to read a short statement of colleague Walter Courtney in support of increasing funding for the prostate cancer treatment program. Walter is the epitome of a man who was enrolled in the prostate cancer treatment program. As a small business owner, Walter provided for his employees before he provided for himself. And when the hard economic times hit, he found himself without the means to pay for his medical insurance. At that time, Walter was diagnosed with prostate cancer and had no means to pay for his treatment. When the prostate cancer treatment program started, he was finally able to get the treatment that he needed. Unfortunately, his disease had advanced too far and he could not be cured. However, Walter was a strong supporter of the prostate cancer treatment program because he knew the importance the program is to men just like him, and he believed that men whose cancer is caught early can be saved. Walter spoke at several previous Sub-1 committee hearings when the program was halted or threatened with closure. I want you to know that Walter would have been here again today to speak to you had his prostate cancer not caused his early death. The number of men on the wait list continues to grow, and we know from Walter's story they cannot wait for their treatment. In closing, we hope the Budget Committee will consider the prostate cancer treatment program needs additional funding so that it may open the doors and continue to serve men like Walter. Thank you.
Thank you.
Members, my name is Sam Wells. I'm with the California Prostate Cancer Coalition and also a survivor. 19% of the men that come into this program are metastatic versus 4% for people in the general public who are coming in for treatment. And the issue with people that are 19% and have to face what we call metastatic, which means the cancer has gotten out of the prostate and is now moving through your body. That's not a huge success factor for a long life. And the point I'm trying to make is that a long wait list exacerbates the problem. You've already got people who've waited too long before they've gotten in for treatment. So your motion to add funding would be greatly appreciated. Something I think we can avoid the same thing happening next year. Thanks.
Thank you. So, members, I just want to note that in the past, we've instituted a 13% cap on administration for the program. We've negotiated a new pharmaceutical contract to reduce the costs. We've eliminated funding for outreach, community education, recruitment. Overall funding for the program has declined while the wait list grows. The action I'm going to recommend is that we augment the program by $1.5 million in funding. Let me see if we have a motion to that effect. It's a motion from Mr. Chesbro, a second from Mr. Bell. Is there any further discussion by members of the committee? Let's call the roll on that motion.
Jones?
Aye.
Bell? Chesbro?
Aye.
Hill? Emerson? Nastandi?
Okay, that motion carries. Issue number 6, Asthma Public Health Initiative.
The Asthma Public Health Initiative is an initiative funded by Prop 99, and it's used to provide local assistance to community health centers to increase the quality of services provided to children that have asthma, both in terms of preventing asthma episodes and improving treatment for asthma.
Okay, so the governor has a trigger proposal that would shift all $1.2 million in the remaining Prop 99 funds from this program and essentially eliminate the program. Anything from finance? LAO? Members of the public who wish to testify?
Morning. Paul Neprath, representing the American Lung Association. We would strongly urge the committee to reject the trigger cut proposal. Asthma in California is a significant public health problem. The programs that are currently being funded by the California Asthma Public Health Initiative in the Central Valley, and I think there are 3 counties that are left participating with this program, have some of the highest childhood asthma rates in the country. They also have some significant air pollution problems in the valley as well that exacerbate our asthma situation, and we would urge you to fully fund this program and reject these trigger cuts. Thank you.
Others who wish to testify? So the recommendation here is that we leave this item open until we get updated numbers in the proposal and the May revise. If there's no objection, we'll leave this item open.
Mr. Chair?
Mr. Chesbro.
Yeah, just momentarily, I wanted to correct something I said a few moments ago when we were talking about the Every Woman Counts. I referred to it as a governor's veto, and it was actually a decision by the Department of Public Health that made those reductions subsequent to the budget adoption. So,
okay, appreciate that clarification. Let's move to issue number 7, the Office of AIDS programs, and in particular the governor's 2009 veto. Welcome.
Good morning. Michelle Rowland from the Office of AIDS. So I believe you want a summary of the previous vetoes. Those vetoes eliminated all general fund support for HIV testing, HIV prevention efforts, and medical care and related support services for the Office of AIDS. In the prevention and testing arena, the general fund represented about 80% of the total resources that we had available, so we continue to administer the Center for Disease Control and Prevention funding about 20%, predominantly to the highest impacted 17 local health jurisdictions. The medical care and support resources represented about 50% of our funds, and we continue to allocate our federal resources from HRSA throughout the state to provide medical care and support services to people living with HIV in California.
Okay, so the governor vetoed $52.1 million in general fund funding after the legislature's enactment of the revised budget last year. Anything from finance? LAO?
Thank you, Mr. Chair. We are concerned about the impact of the governor's veto on, particularly on the prevention programs, and are working with the department to figure out what those impacts are.
Okay, the action I'm recommending to the committee is that we restore the $52.1 million in general fund support vetoed by the governor in 2009. Members of the public who wish to testify?
Good morning. My name is Courtney Mulholm Pearson. I'm here from the San Francisco AIDS Foundation to support this motion. The impact to prevention and testing programs in the state have been devastated by this cut, and we would really appreciate this increase in funding for our programs. Thank you.
Allison Ramey on behalf of the California Primary Care Association. We would support the chair's recommendation.
Michael Martinez on behalf of the Los Angeles Gay and Lesbian Center, in addition to CARE Sacramento, Sacramento Valley's largest HIV/AIDS organization, strong support of the chair's motion to restore these funds. Thank you.
Mr. Chair, members, Rand Martin on behalf of the AIDS Healthcare Foundation. Just want to point out that in the wake of the governor's veto last July 28th, a date that will always live with me, we have had to redirect funds from from the counties to pay for the programs that the state was paying for. There are things that are not being done on the county level because of that veto, and they need to be restored in order to provide comprehensive services. Thank you.
Thank you.
Thank you, Mr. Chairman. Members, Maureen O'Haron representing AIDS Project Los Angeles in support of this recommendation.
Very good. Questions from members of the committee? Mr. Chesbro?
I'll move the chair's
Okay, the motion is to restore the $52.1 million vetoed by the governor in 2009. It's a second from Mr. Hill. Let's call the roll on the motion.
Jones?
Aye.
Bell? Chesbro? Hill? Emerson? Nestandy?
Okay, motion carries. The next is issue number 8, which deals with the ADEP program.
So this is the budget year proposal, the January proposal for ADAP, the AIDS Drug Assistance Program. The governor has proposed an increase of $87.5 million in general fund support to fully fund all components of the program with the exception of the jails, which is the next issue, and address the increasing caseload and increasing drug expenditure costs.
Okay, I want to acknowledge my thanks and appreciation for the governor's restoration of full funding to the ADEP program. A number of us wrote a letter earlier this year in advance of the governor's release of the budget, a letter that followed on the heels of a hearing that I held late last year on World AIDS HIV Day, a hearing that elicited testimony and a great deal of information about the impact of the cuts in this program. This is a program that people rely on to stay alive. This is a program that helps to pay for drugs that are necessary for people to stay alive, and I'm most appreciative the governor has proposed to restore funding. Finance?
I'm sorry, could you please restate that question?
But do you have anything, there wasn't a question, do you have anything you wish to say about this item, Department of Finance?
Not at the only point that we're noting is that the governor's proposal does include elimination of funding for ADAP services in county jails.
Right, we're going to deal with that separately in the next item. LAO, anything on this one? Okay, members of the public would like to testify about this item, I also want to note that I'm going to recommend that we adopt placeholder trailer bill language that would allow us to use ADAP as a certified public expenditure as a way of trying to enhance our ability to bring down additional federal funds into the program. Mr. Emerson, you had a question, sir.
Well, I just had a question of finance, if they had any concerns about this approach. Did you have any thoughts on this? Or?
Not at this point.
anyone who wishes to testify on this item? Okay, seeing none. The motion I'm going to be looking for is the language on page 18, which is placeholder trailer bill language, which the Senate Budget Subcommittee adopted, which we're going to steal for our purposes as well. There's a motion from Mr. Bell, a second from Mr. Emerson. And with that, if there's no further discussion from members of the committee, the motion is to adopt this trailer bill language. Let's call the roll.
Jones.
Aye.
Bell. Chesbro.
Aye.
Hill. Emerson. Nastandi.
Okay, that motion carries. Issue number 9, which is the county jails portion of the ADEP program. Go ahead.
So the budget year proposal for ADAP does include discontinuing coverage of the cost of ADAP medications in the county jails that are currently existing in the participating in the ADAP program. We've not enrolled any new county jails for the last several years because of the fiscal impact. And we anticipate in the governor's budget that we would save about $10 million, and the costs of covering those medications would then shift to the counties.
Okay. Finance, anything you wish to add?
Just one comment that the estimate for this proposal will be updated with the May revision.
Okay.
So if you take action today, that action may need to be amended at a later point with updated numbers.
Okay. LAO?
We support the governor's proposal to achieve general fund savings. We had requested the Office of AIDS to look into the opportunity for counties to participate in this program still at their own cost and still to achieve the general fund savings. Your agenda notes that there were legal and administrative issues raised with this proposal, as well as the savings wasn't very substantial. So we don't think it's a promising approach at this point.
Okay, so I'm going to suggest we leave this item open, but let me see if there's questions. Mr. Bell.
When I was a county supervisor in Santa Clara County, we developed this alternative concept that's mentioned in the staff report. I would like to see the staff, and it saves the state money, okay? So I would like to see the staff continue to work on maybe trailer bill language or anything that would encourage or help facilitate counties that wish to proceed in that direction. And if we need to remove any barriers, that they consider that in trailer bill language, Mr. Chairman. And in terms of leaving the program open, I think when we review it again at the second after the May revise, that if they could come up with some ways to help counties facilitate these kinds of fundings, because quite frankly, we don't want to have counties eliminate these programs in the county jails. It would be a disaster if these programs were somehow eliminated in the county jails because of the inevitable spread of hepatitis and other AIDS and other health problems in general. So I would encourage that strongly, that we look at the staff to work on removing barriers.
It's a good point. So let me ask if the department, the LAO, and our staff would report back to the committee on whether there's anything that we can do to remove impediments to other counties taking the sort of approach that Santa Clara County has taken, as identified in the staff report, and then we'll leave the item open for the moment if there's no objection. Okay, thank you, Mr. Bell. And I couldn't agree with you more in terms of the importance of the program. Issue number 10, generic disease testing program. Do you think they're just like hemming and hawing right now and goofing around? Welcome.
Again, I'm Vicki Orlick from the Center for Family Health. I'm the Assistant Deputy Director. The Center for Family Health does oversee the genetic disease screening program. The genetic disease screening program is two programs. It's the newborn screening program, which screens approximately 560 newborns, every newborn in California. And the second program is the prenatal screening program, screening pregnant women, and caseload is anticipated to be about 450 for the budget year. It is a fee-based program. It charges $162 for the prenatal screening program. Excuse me, $162 for the prenatal and $103 for the newborn. Both programs do provide integrated screening services. That includes follow-up and diagnostic. It is an integrated approach. We are requesting an increase of $472,000. This is an increase over current year, and this is primarily related to the expansion of the program for prenatal. It was first trimester screening that was implemented in April of 2008. So these costs are associated for reagents and follow-up type costs.
Okay, Finance, do you have anything you want to add? LAO? Anyone who wishes to testify from the public? Okay, my recommendation on this one is that we would leave this item open for the moment. There's no objection. It's a very laudatory program. It helps a lot of newborns. But I think we're not going to take any action on the request at this time. Issue number 11, the Valley Fever augmentation.
Good morning, Mr. Chair. Drew Johnson from the Center for Infectious Diseases with the California Department of Public Health. And the agenda stipulates they wanted to have a little bit more data on California morbidity. Valley fever is contracted through a soil-dwelling fungi, which is endemic through the San Joaquin Valley. It's contracted through the inhalation of spores. Nationally, there's about 150,000 new cases that occur. Approximately 60% of these are asymptomatic, and then the balance, the 40%, usually present with influenza-like illness symptoms, including cough, body aches, fever, etc. In California, the reported rate is about 7.4 per 100,000 people, which annually is about 2,800. This is likely to be a gross underestimation, though, of the actual number of cases, primarily because of the asymptomatic nature of the disease, as well as those who are actually do present with symptoms often don't seek medical care. They're often sick, get home and well in bed, and then return. Geographically, in California, 74% of the reported cases are within the San Joaquin Valley. Kern County reports the highest incidence every year. Over a 12-year period of data that our office looked at, it has an incident rate of about 195 per 100,000. So the San Joaquin Valley is predominantly hit with valley fever disease. Our proposal here, it's included in the governor's budget, is to continue $1 million in vaccine research. The research has been sporadic over the years, as outlined in the agenda. Currently, they've been working on, the Valley Fever Vaccine Project has been working on both a live attenuated vaccine as well as an inactivated vaccine with mice. The department's $1 million appropriation is by far the lion's share that supports the vaccine research, although other resources that they utilize includes some foundation grant and some donations and fundraising from local entities.
Okay, Finance, do you have anything you wish to add? LAO? So the request here is for $1 million for Valley Fever research. Oh, LAO's microphone. Well, we can hear you without it. Go ahead.
Thank you. In light of the general fund problem faced by the state, we would not recommend continuing this one-time appropriation for medical research.
Okay. Anyone who wishes to testify from the audience? Okay, this is a perfectly laudable program. I guess the question I have is, why isn't the private sector doing this research? And given the state's situation, I'm going to support the recommendation that we reject the governor's proposal on this. Any further discussion from members of the committee? Okay. I'm looking for a motion to reject the proposed $1 million for this program.
So moved.
Motion for Mr. Chesbro, second for Mr. Hill. Let's call the roll.
Jones.
Aye.
Bell. Chesbro.
Aye.
Hill. Emerson. Nastandi.
Okay, the last item, and then we'll recess the committee and we'll resume immediately upon the adjournment of session, and we will resume in room 447, which is a slightly bigger room than this. Therefore, fulfilling my promise. Not quite as big as I had wanted, however. But I guess I'm constrained by other committees that are meeting. So we're going to resume in room 447 immediately upon adjournment of the session, and I'm going to switch up the order a little bit and ask that we start with the Department of Healthcare Services budget when we resume after the close of sessions. But we're going to close out on the Department of Public Health, and we're now doing issue 12, ambulatory surgical centers licensing. And I wonder if you could share with us a little bit of the background of this issue.
Hi, thank you very much. I'm Kathleen Billingsley with the California Department of Public Health, and I have responsibility for the oversight of healthcare facilities in the state of California. They are licensed by the state. The issue of oversight of ambulatory surgery centers is rather extensive and has gone back for many years, but a final decision in Capon versus Shrury resulted in the fact that physician-owned ambulatory surgery centers could no longer be licensed by the state of California. So the administration is incredibly interested in continuing the oversight and licensure of these facilities, and unfortunately we have not been able to come to resolution with that. But again, very, very committed by the administration to make sure that we move forward with this. I would like to point out that this last year, CMS and the federal government gave the licensing and certification program $1 million to conduct oversight of the current licensed 460 ambulatory surgery centers. We are proceeding with that. We conduct 1/3 each year, and we'll be doing that for the next 3 years. But it is limited to the 460. When recently attending sessions in Baltimore, I found that other states aren't challenged with the fact that they cannot license other ambulatory surgery centers, and they are conducting oversight of facilities, which unfortunately we're not doing in California. So I think it reemphasizes that. We are also finding with the oversight that we're conducting right now, we're focusing, of course, a lot on infection control issues. We are finding multiple deficiencies, and at least half of these inspections have resulted in revisits and re-inspections and deficiencies. So I think from a public health perspective, the administration as well as the California Department of Public Health is very interested in seeing licensure pursued.
Okay, so here's the problem. We have these facilities called ambulatory surgical centers. They are a lower-cost alternative to inpatient surgery at hospitals. They are, in some cases, owned partially or solely by physicians. They are good things because they allow people to have access to health care at a lower cost. The Department of Public Health used to license them. In 2007, as a result of a really poorly reasoned appellate court decision, the Department of Public Health concluded it no longer has authority to license them. I personally disagree with the Department of Public Health's interpretation of that decision and think you could still license them, but I'm not the Department of Public Health or the governor. So you have made that decision. You're not licensing them anymore, which means that we have literally, I don't know, how many of these facilities without licenses now?
I think that this probably represents 1/3 of the basic number that
and the
are
basic
out there,
number is?
which is 460 right now. So there are probably close to 3,000 facilities in total. Depends on how you want to define all of those. But basically, we have a number of facilities that are ambulatory surgery centers that are physician-owned that have no licensure and no oversight.
Okay, so this is a problem. And there has been repeated efforts made by this legislature and the administration to come to agreement on a licensing regime, and I appreciate your commitment to continue to try to do that. But in the meantime, what's happening is that these facilities are ineligible to get reimbursement from Medicare and Medicaid for the use of pharmaceuticals at the facilities. And as you can imagine, it's important to have pharmaceuticals at a outpatient surgical facility. So we've got no licensing and an inability to get reimbursed for procedures that are being performed there. So what I want to propose is some budget trailer language that would authorize the Board of Pharmacy on a limited basis to provide a license for purposes of allowing pharmaceuticals to be used at these facilities. It'll be fee-funded. In other words, there'll be a fee collected currently by the Board of Pharmacy to cover that activity, but it would at least allow these facilities to continue to do their work, and will then continue to work more globally with the Department of Public Health on a solution. But I think we need to act now, not wait until the end of this legislative session to fix something that's been a problem since 2007.
Currently, if you are a physician-owned ambulatory surgery center, you can purchase your drugs and take your drugs to the ambulatory surgery center because you're not allowed to obtain a license from the Board of Pharmacy so that the facility itself can order the medications. I think that
we got doctors driving drugs in with their cars to the facility. The facility
they can
buy
bring
them
those
themselves.
to the facility itself. We unfortunately don't have authorization to change that. We're really looking at a more global public health issue in terms of oversight, not just of being able to be able to provide the pharmaceuticals to a facility, but to provide that oversight and licensure, which we believe protects the people who are obtaining the services there.
I don't disagree with that, and we're happy to work with you on a global solution, but there were 2 bills put on the governor's desk, by my count, that provided a global solution that were vetoed. So clearly, and those were bipartisan bills. Those were bills that were jointly authored by Republicans and Democrats going back to, 2007. There was a Plesha bill in 6, there was a Plesha bill in 7, there was a Plesha Jones bill in 08, there was a Negretti-McLeod bill in 09. So in the meantime, the House is burning down. So I appreciate and look forward to working with you, as do other members of the legislature, on the global fix, and I take at face value your commitment to do that, because I know you're committed to doing that. But I think we need to act now on this issue. Okay, there's a motion from Mr. Emerson. Is there a second? There's a second from Mr. Bell. Do we want to hear from members? We should hear any members of the public who wish to testify on this item. Briefly.
Beth Capel on behalf of the Service Employees International Union. We have a slightly different perspective on this issue, and which I want to share with the committee in light of the trailer bill action that you're contemplating. Like the Department of Public Health, we're concerned about infection control in these facilities. We're also concerned about the prevalence of never events, including leaving surgical objects inside patients. We are also troubled that in our long experience dealing with these surgical clinics, they do not observe the staffing requirements that are comparable to those in hospitals, staffing requirements that were established in 1974 when most of these surgeries were performed on an inpatient basis. So that, for example, they do not require that there be a circulating nurse in the operating room. They do not require that there be a registered nurse in the recovery room. We have worked with the various parties and with the administration on trying to assure a global solution. A partial solution which allows bad care to continue is troublesome to us. We were not aware of this motion prior to today, but we wanted to put it in the larger context as the chair suggested. Thank you.
Very good. Thank you. Okay, so there's a motion, a second, further discussion by members of the committee. All right, let's call the roll on the motion.
Jones.
Aye.
Bell. Chesbro.
Aye.
Hill. Emerson. Nastandi.
Great. I apologize for our having to recess, but we are in session now, so we're going to do that. I want to thank the Department of Public Health and all of the managers of the department for their very able presentations, and I want to thank the Department of Finance and LAO, and we'll resume immediately upon the adjournment of session. Thank you.